ESICM experience review session. I'm going to cover most topics around sepsis and COVID-19 that we published over the last few months. Just to acknowledge, I don't have any financial conflicts of interest other than there are some intellectual conflicts related to the research I do. Just like the previous speakers, I've kind of picked some key topics that I think you will see more of going forward. The first paper is a lovely understanding the disease summary by Jim Russell, Noella Mayer, and Keith Wally. There are two epidemiological principles and one biology principle in this paper. The epidemiological principle is the confounding and instrumental variable. So they use the example here that if smoking causes lung cancer, if you know that you can alter the behavior of smokers by increasing the tax, it can reduce lung cancer. In other words, the confounder is the environment and the tobacco tax is the instrumental variable. The reason why this principle is important in biology is that proteins are the effector molecules that have got kind of host response effects. So if you take an example, there is a relationship between the protein and the phenotype, or the protein to phenome relationship, and there is also a relationship of the protein to the genetic makeup of an individual, in particularly the SNPs or the polymorphisms. So here the authors make the point that if we know what are the polymorphisms that are associated with a change in a particular protein, which is then associated with a clinical feature, you can change the way a patient's illness changes over time. And they use the example in this paper of immunoglobulin gene polymorphisms and the immunoglobulin concentrations in COVID-19. And this principle has been shown in other contexts. So, for example, there are complex traits associated with polymorphisms. There's also a drug discovery angle to this. So you may have kind of read lots of paper from one of my colleagues, Kenny Bailey, using the genomic study, where he has highlighted the idea of finding drug targets based on genetic makeup of an individual. So an important conceptual argument to keep in mind when you read these papers, and going forward we'll probably see more and more of these sort of informatics related work to inform the way we look after patients with sepsis. Kind of another example, again, from understanding the disease. The reason why I picked this paper is because we are going to see more and more of these patients who have survived COVID-19 with or without lung injury coming back to us with either related diseases or unrelated diseases. And one of the diseases that we are going to see more of is the interstitial lung disease. And post-COVID-19 interstitial lung disease seems to be different compared to the standard idiopathic pulmonary fibrosis literature. And the figure some kind of divided into two halves. On the left-hand side in blue is the idiopathic pulmonary fibrosis, and on the right-hand side is a post-COVID ILD. The exact mechanisms of post-COVID ILD are still being worked through, and the hypotheses that people are testing are that there is viral persistence in niches that you can't immediately identify, or the viral infection has changed the immunological tolerance and altered it, and the altered immunological tolerance causes autoimmune lung injury and fibrosis going forward. And the reason why I think this becomes important as clinicians is that patients post-COVID-19, we probably need to start asking that specific history of have you had COVID pneumonitis or COVID in the past? Because some of the pulmonary changes that we see could be explainable by previous COVID disease. And this also has got treatment implications in terms of immunosuppression for specifically targeted at lung disease. And this review was written by Dr. Mehta, based at UCL, and she also highlights a few therapeutic targets in this context. And again, the authors emphasize the point here that not every interstitial lung disease is immediately transferable to post-COVID ILD. It's a different illness. So that's the reason why I picked this paper up. Again, it's a worthwhile read if you have, it's 1,000 words and a lovely figure. Then I kind of picked a couple of papers which have got, I think, clinical practice value. So this is an example. This paper is a machine learning derived sepsis bundle of care. Not that I completely agree with all the things the authors say, but it's an interesting notion to think about, because you're going to see more and more of this sort of machine learning and AI approaches for data mining. So the authors use two databases. You probably have heard about the MIMIC database, and the other database that they used is the EICU-CRD database. And what they did here is to divide the original MIMIC4 database into a derivation cohort and an internal validation cohort, and then use the EICU-CRD as an external validation cohort. The authors then took the surviving sepsis campaign guidelines. The top, out of the 79 recommendations, they were able to map around 22 of them onto the MIMIC4 database. And then they asked the question, if there was compliance with with the surviving sepsis campaign guidelines, do you think that the patient outcomes would be different? There are lots of methodological challenges with this sort of work, including residual confounding. But the interesting point then the authors do is to do the propensity matching of patients who got all of the different things that they identified using logistic regression models as significant variables. As if they got everything in that bundle, they labeled them as bundle treated patients. If they did not get one or more of them, they treated them as bundle negative. And what they go on to show is that if you get compliance with most elements of this, all of the bundle elements, then you have a difference in outcome. And they kind of explore some of the subphenotype literature, again, published previously in JAMA by Chris Seymour and colleagues, the alpha, beta, gamma, delta subtypes. And they show that some of the points that they make may be related to subphenotype differences. So some interesting idea. This is not the one to change your clinical practice, but it kind of sets a hypothesis for people to test going forward. This would kind of become what one would label as complex intervention in a future clinical trial. This is some of the work that came out of the REMAP-CAP trial. In the REMAP-CAP trial, convalescent plasma did not change outcomes in patients with moderate to severe COVID-19, and that was published in JAMA. In this sub-study of around 1,300 patients, the authors did a cytokine panel to then do an unsupervised analysis of the cytokine panel to highlight 3 subtypes of COVID-19. And then what they did was to look at the treatment effect differences between the 3 subphenotypes. And what the authors show is that subphenotype 2 and 3 have got a very different treatment effect compared to subphenotype 1. And in fact, if you were to give subphenotype 2 and 3 convalescent plasma, you increase the risk of adverse outcome. In other words, usual care is better if you're in subphenotype 2 and 3. So some of the things to think about here is how the unsupervised analysis and biology changes the way we respond to treatment. And again, this is not the only paper thinking about this concept. There are other papers in this space doing similar sort of analysis. And this is a randomized control trial, again, an early proof of concept idea. This trial is called as a RECO sepsis randomized control trial. RECO is remote ischemic preconditioning. And the hypothesis being that if you reduce the blood supply to one of the limbs intermittently and then reperfuse the limb, overall outcome of sepsis could be different based on some of the inflammatory response and the immunological responses from this remote ischemic reconditioning. And the study was a multi-center study in France. These were patients with adults with septic shock, and the intervention was remote ischemic preconditioning as described there, and the sham RECO was the control arm, and the primary outcome was SOFA score by day 4. And out of the 600 odd patients screened for eligibility, they randomized around 180 patients. And as you can see from the figure on the right, it looks like if you are in the control arm in the RECO group, there is a there is a difference in trajectory, but it's not a strong enough signal for the authors to conclude anything robust other than to say more work is needed in a targeted population. So this paper, original paper of helmet COVID randomized control trial was published in JAMA, and the trial essentially was done by the Saudi Critical Care Trials Group. And the question the authors were asking there is the effect of NIV on helmet versus usual respiratory support and mortality. The primary outcome was 28-day mortality. They randomized 332 patients, and then they analyzed roughly 320 patients, broadly equal number of patients in the helmet NIV group and the usual respiratory support. And they show that the primary outcome was not different, which is 28-day mortality. But it leaves us with the question, primary outcome of 28-day mortality is a rather early outcome. Some patients could have been intubated with a longer mechanical ventilation duration. Does the longer term outcome change? And that's what this paper addresses. That's published in ESICM, where they followed up these patients up to 180 days, and then they asked the same question, is the mortality and the health-related quality of life different in patients who got helmet and IV compared to usual care? Even at 180 days, there was no difference in the primary outcome of mortality with the helmet and IV versus usual care, and the quality of life was also not different. One of the challenges, as I said earlier, is those who got intubated may have a different health-related quality of life anyways. So they do that subgroup analysis and say that there is actually not that much difference whether you got helmet and IV before you got intubated or not. So an interesting work, because we are, like I'm sure, like your practice, we are using more and more non-intubated respiratory support, including high-flow nasal cannula, CPAP, etc. So this sort of literature helps you to think whether am I actually harming them longer term? Seems like the general signal is that you don't harm patients with this sort of intervention. So I've just kind of given you a very brief summary of the few of the papers. We, like previous speakers, ESICM wants your papers. Please come and contact us. My email is there, and you can email any of the editors. We go from translational biology, bedside observational studies, and RCTs and secondary analysis. And we kind of are reasonably quick, 3 days from submission to initial decision. And we are nice people. You can see us on our Twitter feed. Thank you very much.
Thank you very much, Manu. Are there any questions? I have one question for you, Manu. You talked to us about interstitial lung disease. Are there any potential therapeutic for this disease?
So currently there are no trials that show targeting post-COVID ILD, but people have started using extrapolated literature from ILD. And the things that people are thinking about is to target the TGF-beta pathway for long-term fibrosis. That's one option. And if it is an acute inflammatory exacerbation, people think about tocilizumab, anakinra, that pathway, because that's the other pathway that is activated. The role of steroids is even more uncertain than in ARDS or acute ILD.